Okay. Is Susan joining or not yet? Okay. But we can start. Assalamu alaikum. Assalamu alaikum, everyone. Thanks for joining us. My name is Waidi. I'm the medical director at CHI. Sorry for some due to some technical challenges, we're late a little bit. Inshallah, we'll start now. So before I start, thanks for joining us. Um, we are here. We are here today to talk about the MDS changes, the upcoming changes. Hopefully, you had the first session about the MDS. Uh, about the MDS before. Probably most of you know what the MDS is, which is the minimum data sets, and hopefully most of you had a smooth implementation of the MDS phase one. There are few fields were missed maybe or get delayed due to technical issues. We will update you about these changes during this time, and we welcome any questions regarding any of these fields. And hopefully, you will have also smooth implementation with for these fields. We will also try to answer any questions that's related to either current fields or the previous fields. And please leave your comments in the chat if you have questions, and we can start now. A second. Musa'ad, if you can add Susan to the call. She's trying to join. Musa'ad, it's my
Sure, sure.
okay. We'll wait for 1 minute. Did Susan join Saad?
I was still waiting for Miss Susan. Just 1 minute, please.
Okay, we'll wait for our HIM expert to join. She will be with us in a second. Let me talk about a few things when we talk about the MDS. So the MDS, these fields are required or mandatory when they are when any claims or prior authorization are being submitted. So that's mean, in another word, these fields need to be filled correctly based on the guidelines. And if it were not applicable, you can always choose an applicable or the permissible values that is allowed you to submit or choose when you submit the prior authorization or claims. Welcome, Susan. Um, can you hear us, Susan? Susan, can you hear us? I think she's not able to unmute herself. If you allow mic or camera. Saad, she cannot present. She is not a presenter.
Okay.
We can. Susan, we can hear you now.
Hi. Good afternoon, everyone.
Hi. Okay, Susan, you can introduce yourself to the team.
Yeah. Hi, everyone. My name is Susan Young. I'm the Senior Advisor for Health Information Management at CHI, working with Dr. Weil and the team on the minimum data set. And happy to see such a good turnout again for the session.
Okay, so you can make a full presentation mode slide. Okay, so starting with the current changes. So in addition to the previous minimum data set that we published a few months ago, these are the fields that will also be required or mandatory within this update. So this is the second minimum data set update. And that will include the current field you can see, the encounter profile, the emergency, the provider type, the patient demographics, and the supporting info. Currently, there is the conditions are either optional or non-applicable, and the new change will be for these fields that they will be mandatory fields. So that means in any prior authorization or claim you are submitting, you have to fill these fields. So except, for example, for encounter profile, it will be only mandatory for all, it will be always mandatory except for vision and pharmacy. And with the emergency, the field, in the old MDS guidelines, it was institutional, but with the new MDS changes, it will be professional with emergency encounter type. So this is the change. If you are familiar with the Nafis profiles, you can find these changes within Nafis profile. The provider type, it's a new field. It's introduced now, and it will be mandatory. And that will be mandatory also any prior authorization or claims. And patient demographics, it used to be optional. Now it will be mandatory for all prior authorization and claims. And supporting info also will be mandatory for all prior authorization and claims. So if any of these fields are not applicable, you can always choose the permissible values. Do you have any comments on this, Susan, before I move to the next slide?
No, I think you've covered everything, Dr. Weil.
Okay, so next slide, Saad. Okay, so and as I mentioned before, if there is a missing or inapplicable supporting info, and that might be the case for a few cases, or if the patient occupation, for example, which is one of the patient demographics, are not available, you can use any of the permissible value, which is like a noun and an applicable or missing. So all these values still can be clicked and it need to be checked. So it's a mandatory field need to be checked if it's not applicable to choose the permissible values.
Yeah. So I'd just like
Can you
to
give
add,
an
Dr.
example
Weil.
for? Yeah.
Sorry, if you don't mind, Dr. Weil, I'd like to add here so everyone understands why we're using this approach rather than leaving a field blank. The reason is in the data set, when we receive the claims, it's not always understood whether something is intentionally left blank or it's by mistake. So the reason why we make these fields mandatory to fill with some response is that we know that you have looked at it and you are entering the data. So that we don't have gaps in the data set required.
Yeah, so I will repeat what Susan mentioned, maybe in a different way. So the reason why we are asking to fill this is because we would like to make sure these fields, these information are not available or missing, and you, as a provider, you will check that by submitting the claim and mentioning that these are not available, not applicable, etc., to make sure these data are complete. And to be honest with you, we noticed a few practices with a few providers. When they provide these data, they always check the non-applicable or permissible values for all claims and all prior authorization. And very soon we'll be notifying these providers who are actually using the permissible values for all claims of prior authorization. And we urge you to use it the correct way, because payer will be able to reject your prior authorization and claims based on the fields that you filled. So if you are using non-applicable or permissible value for all claims and prior authorizations, you will that be on you because you checked it by yourself. It's impossible to have it and miss it for all your beneficiaries. So please make sure use the permissible values when they are appropriate. And we will launch very soon a tool to monitor all these permissible values and the percentage of completeness on Nafis, and we'll notify you if you are using it incorrectly. Sample of default accepted permissible values. So I think there was 4 or 5 permissible values. I don't remember it, but for example, non-applicable or unknown. So if for occupation, for example, it's unknown, you can choose the permissible value unknown. I don't know if Rabia is here. Rabia can give you the exact values, but if all your claim, the privatization, yeah, Hannah Rabia. If all your prior authorization and claims are unknown, that's impossible. So we will be able to monitor that, and please use it appropriately. Go ahead, Rabia.
Yes, just few example. For example, blood pressure. There is a way to say there is a URL called absence of blood pressure, and the value I think is 9 point something. Don't take it literally. It's on the codable concept, all clear. Plus, there is a sample which only contains permissible values in the unified portal, so you can download it and see exactly how each one is done. And as Dr. Wael was saying, don't use it excessively. Just when it is really unknown, you will report it as unknown.
Yes, it's very important that everybody. Sorry, go ahead, Dr. Weil.
No, go ahead, Susan. Sorry, there is a delay in the sound. Go ahead, Susan. Can you hear me?
Okay. So it's very important that everyone understands the purpose for this. We have given this option for you to be able to record appropriately and fully the information that you have on hand. Okay. This is just like documentation in a medical record. You need to document fully and appropriately, follow the guidelines, and understand the reasons why we're collecting this data. And this helps us know where there are gaps and where additional guidance may be required, additional education, and clarification of fields. So these are some of the outputs of having all of these data fields mandatory. Thank you.
Exactly. So, and another example, when there is an online visit, for example, an encounter, maybe vital signs could be missing at that time. I hear a few questions, and some people refuse. Yes, we understand that, and but some of the claims of prior authorization might require the patient occupation and the patient gender, or and the patient demographic data. So if this is the case for few cases, you can always use the permissible value. But I'm talking about a provider who is 100% providing permissible values. That's it should be unacceptable. So again, we will have a tool to monitor all these permissible values and if they are filled appropriately. In addition, if these fields are filled with one value, for example, we have noticed few providers who are using fixed text for all the claims of prioritization. For example, chief complaint will be filled with one value or one text for all the claims. This is are being monitored, even if it's free text. So again, our goal is to make sure you are linked technically at the current time, but we will monitor the values. And this is a data quality issue, and payers will be able to reject your claims or prioritization based on these fields. So we urge you please to use it correctly when it's appropriate. We understood that there is a huge effort from the physicians, from HIS development to capture all this information at appropriate time. But again, we are telling you now, please invest in this in infrastructure, in your HIM departments, in your HIS system to make sure you are capturing all these information efficiently and quickly. Otherwise, you will be faced with rejections if these data are incomplete. The reason why permissible values are there to allow certain condition, not to use it by default. We noticed that a lot of people, again, I'm saying it many times, it's not the default value that should be provided. And then in the near future, we will have a reasonable reason why your claim should be rejected. And this is also require a lot of education from your providers. If you are filling these fields, you need to make sure you are filling each field with the right information. So we understood that in the past, chief complaint used to fill all the data, but now the data need to be structured: physical exam and physical exam, treatment plan and treatment plan, and etc. And even the values for vital signs, we are working on putting certain ranges to make sure these values are correct. And there is also few changes coming to Nafis. Maybe Susan can talk about it also more in the future to be able to validate these values even more, to make sure that we have a good quality of data.
Right. So what I'd just like to add about the permissible values, there are certain use cases where permissible values are entirely okay, but we have defined those very clearly for you. And that would include in the vision and pharmacy claims, there are certain things that are not like vital signs that are not required. So those can be defaulted. However, you need to make sure you follow the appropriate use cases. And with regards to vital signs, as Dr. Weil mentioned, what we have done is ensure that the fields will be formatted. So a temperature, for example, must be expressed in Celsius, and the field will be 3 characters with a decimal between the second and third. So that would let you know that you can't have a value over 100, you know. And then we will add ranges as well using clinical edits. For example, we'll give you an example. We looked at some claims where the heart rate or the pulse was expressed as 8,000. Humanly impossible. Might be okay for a hummingbird or maybe one of the small insects, but for a human, that's impossible. So there'll be more validations built into some of these fields to ensure that we have credible information.
Correct. And then somebody asked, I will go through some of the questions really quickly. What's some example of supporting information? Could be a lab result, radiology result. It could be the medical reports. All of these are supporting information. Again, these information will be also available very soon the patient will be able to see these data that you are submitting for them by themselves. So make sure you fill it correctly. Otherwise, the patient will be able to see it and know exactly what you filled. And if these data are invalid, it will be transparent between the patient and insurance company. So we talked about the permissible value. We talked about patient demographics. If it's supposed to be provided from the payer, yes, this is very soon within inshallah Q1. We will have some of these information, especially the patient demographics from the patient registry and from the insurance. You need to fill it, but we are very soon. We are in the final phases of linking some of the registry information and patient demographics by defaulted by Nafis, and but right now it's manually provided. Okay, then I will go. As a pharmacy, we expect 100%. So for Abdurrahman Maflah.
Yeah, I think I answered that question already, Dr. Weil. In some cases, permissible values
not permissible values.
are accepted.
Yes.
Did we answer the question about the
for the
morphology?
claims of January? Morphology, go ahead, Susan. No, I think I did not
I'm sorry, Dr. Weil, I wasn't sure which question you were on.
Yeah, you answered the morphology one, yes.
Okay. So the question is for the morphology disease list or the code list is required. Okay. You can receive this or obtain this from Saudi Health Council through their support pages. So what you need to do is contact them, provide them with your certificate that you are licensed to use ICD-10, and they will provide you with the updated content, which contains everything that is related to the ICD-10 AM and ACHI and ACS coding standards. The morphology code list is included in this package.
Okay. So there is another morphology question, Susan. How can we submit morphology report for all follow-up patients visiting for medication refill? I think if I understand that correctly.
Yeah, if the patient has a cancer diagnosis, you would always report the morphology along with it. So there is a range of codes that are required, and they always come as a package.
Okay. So, and then the second question is that can you explain occupation values based on what? From where we can retrieve this data, the value will be pulled when we check the eligibility. Very soon, this will be the case, but right now, as I mentioned, it need to be filled from the drop-down menu that you have from Nafis profiles. So that's how you should fill it now. Yeah, go ahead.
Yeah, and those values are very broad values. It doesn't give you the specific occupation. It gives in categories like administrative or agriculture or military. So it's at a very high level.
Okay, and then we have another question about what regarding making data mandatory on the payer and innovator response. We are working on it, as I mentioned. Can the URL to access technical documentation? It's available on the piece profile. Okay, for copying request suggested Sahati's wish list practical. Will create claim. Okay, for Omar, he's asking maybe Rabia for you this question. Omar Ihtisham is asking for copying from request. What is suggested by Sahati here is a wish list, not practice. All considering this means payer will create claim request JSON level information for each individual claim. Rabia, can you answer that?
Okay. Let me give two options because first of all, Omar, copying from a request is a choice made by the developer. It's not something that the developer has to do, otherwise he can't do anything. This is one thing. To fix it for claims which you received before MDS in particular, because after MDS you will have it. You can copy from request. One of the options is before you put the object. There's something I believe, I'm not a developer, so I've been in contact with them. There's something, a condition called if null, then use this default value. If you put it, then before you paste, when you parse it, when you parse the patient, for example, or whatever the profile you're talking about, and you find, let's say, occupation is not there, it's a null value, so you insert it in some way. Of course, the developers will know more than me in this way, but there's a way, instead of copying as it is immediately, modify it if it's applicable, and then put the value that you need. This way it will pass through Nafis. But if you copy blindly, then of course it will not pass.
Hopefully that answered your question, Omar. Okay, from when the new MDS would be effective in OBA and production? Saad, do you have an answer? I don't remember the exact dates. Saad, can you hear me?
I believe it was 27th of the last month, Dr. War. If I remember, if it was on Friday or Saturday, so 27 or 28, if I remember correctly.
Okay, yes, and that was for claims with activity dates or service dates from the 1st of November.
Yeah, talking about the new MDS, Susan, sir.
Yes, I'm talking about the new MDS, not, we're talking about what went live
Yes.
in December, but it's for claims from the 1st of November.
Okay. So then what about conditional readings? I don't understand what do you mean, Naji. Do you understand that, Susan? Conditional readings?
No, I'm not sure if this has to
you
do with
mean
vital signs.
Yeah, vital signs, that means, as we said, that it's you can use permissible values if they are not applicable. Okay, Muhammad's here, he said we need more time to fully implement all mandatory roles. Sahatib, do you have an answer to that, Rabia?
My answer is that the MDS has been on OBA for I don't remember how many months now. So, and it has been on production for a month. So more time, Nafis will not allow the claims to pass unless they strictly follow the MDS rules. It's not about needing more time. There was lots of time, but unfortunately, it wasn't done by some parties. So, but now you have to you rest for time. You need to finish it because Nafis will not allow to pass unless it's following MDS strictly.
Thanks, Rabia. Okay, periodic changes in Saudi FDA and GTI codes are troublesome from a HIS point of view. For example, codes used in December 1st to 31st change in January 1st will fail in submission with error wrong codes. What is the long-term solution for this problem? Do you have an answer for that, Rabia, for the Saudi FDA codes issues?
I believe there's a change, but I don't know the date on this. But I believe there is change where GTINs will be replaced by SFDA codes.
That is there. That is correct. That's in the pipeline.
But I don't have the date for it, so I can't give dates. But it is there. I know it is there. In this way, you can use you can just download from SFDA website, and it will be correct immediately without any need for GTINs or outdated GTINs or stuff like this.
Thanks, Rabia. Another question about morphology code, Susan. We need a morphology disease list, the ICD-10, which I belong to morphology.
Yeah. So as I mentioned previously, you can obtain this from Saudi Health Council. So if you have already your certificate or certificate that you are licensed to use ICD-10, you need to send that back to a Saudi Health Council and ask them to provide the updated documentation, which includes the morphology list.
Okay. Susan, as an optical shop, we can use permissible values. The answer is yes if these values that do not apply for you. For Saudi FDA, I think we just answered it. What does exactly mean can you answer that, Susan? What do you mean by provider type?
Okay, provider type is the type of facility And there is, and Rabia, please confirm that I have the right field here. The definition is the type of facility, the categorization. So you're either, it's a hospital, a medical center, and so on. There is a drop-down list of valid values for this field. It lets us know if you're a clinic,
If you can
you're a
put that-
hospital, a pharmacy, an optical shop.
Okay. Thanks,
Also,
Susan.
just one last
So we
point.
failed. Yeah, go ahead.
If your provider type is not listed, there's also another. Because we're working on the list to enrich it so that everything is there, but it will take some time. So for the time being, you can use other if your provider type is not listed in the specific ones. So it will not be blocked by Nafis.
Thanks, Rabia. We have another question about the morphology code.
Okay.
So it said that, go ahead, Susan. Do you have something to say?
Can you read the question, Dr. Weil? I'm not following on the same place, I think.
Yes. So they said that facing an issue regarding filling a claim that contains medication were approved by insurance company for treatment for cancer. It was blocked by Nafis because it has no quality. And it's refused to submit the claim because the missing information that wasn't provided by the insurance itself. So there is a challenge with submitting a claim for a cancer treatment with no morphology codes.
Okay, this is cancer treatment that was provided, and this is either an inpatient or outpatient claim, if I understand. So anytime you submit a claim where cancer treatment has been given, you're giving the service, which is with the item code. It'll either be an injection or an infusion, and you'll have the medication code, but also with the diagnosis. Let's say the diagnosis is breast cancer, which is C50 point whatever. You also need to submit a morphology code. And that might be, an example of that would be M3000 /3.
Yeah, I think
Again,
his question also regarding the payer. The payer is not accepting these fields yet, or Nafis, because it wasn't clear for me. Do you mean Nafis is not accepting, or the payer?
He's saying, I'm reading it here. My understanding is that Nafis is blocking it, which is appropriate according to the new minimum data set changes. But the rest of the question states that this has not been provided by the payer. The morphology code should be coming from the provider. I hope that we're understanding your question correctly.
Yes. Moving to the next one, can you tell what is mandatory field and supporting info for the patient on outpatient? So for supporting info, as I said, it could be a medical report, medication report, a lab results report, or radiology report. So any of these fields can be supporting info. Could you please repeat again morphology? So I think Susan already did. What about chronic disease that have many follow-ups visits? Should we send the MDS from the first visit, or should we request that practitioner added to each visit? So this is a very good question, Mr. Mahmoud. I think every single encounter should has its own MDS, although some of these fields can be borrowed from a previous encounter if they are unchanged. For example, previous surgical history. Do you have anything to say, Susan, about it? Go ahead.
Yeah, I would say that the you need to think back, and your clinical teams are very important in this issue, and you need to consult with the clinical teams on this. There are documentation standards through accreditation, and that define what information is to be collected on each encounter. So it needs to be documented, and it should be taken from the actual visit itself. If the chief complaint is the same on each visit, and it's documented by the physician in the visit, then you should be able to take it out of that individual visit and put it on the claim. You shouldn't be copying from a claim submission point of view from the initial the initial visit. Okay, each visit has its own documentation in the patient medical record. And you need to make sure that the results that you report are linked to those visits. The exception for that would be something like the patient demographics, like birth date and so on. Those are static and come out of your HIS system. They're not encounter related. Those are patient related. But everything else should be encounter specific.
I agree. Okay, so for Mr. Ahmed, can we start versioning MDS so we know which MDS update we're talking about in the future? Do you have an answer to that, Susan?
Yeah, this is the plan. So the versioning of the MDS data elements is identified within the NAFIS profiles and codable concepts documents. It will tell you when the field was added, and there's also documentation of when changes occur. So, but we may, this is a good point, we may start referring to the different releases, and that's something that we'll take into account. So thank you very much for bringing this up.
Okay,
this is very similar to what we do with the code set versions. So for instance, we have SBS version 1 and version 2 so far.
You said so. '24, now we don't have any changes. Is that correct, Rabia?
Sorry, come again, please, because it's
And,
breaking up from your end.
He's asking if there is any new changes in 2025. All the changes have been already applied in 2024. Is that correct?
We both know that lots of changes are coming. I think several times even Nasreen told them that a lot of stuff like clinical edits and the HB1 AC, which is coming soon also, and all other things. Yes. MDS, if we can consider MDS phase 2 as part of MDS, then this is the change that's coming related to MDS, which is HbA1c and chief complaint switching to normal CT instead of ICD-10. Under the label MDS.
So there is a coming, and then yes, there is few changes are coming very soon, if you don't mind. But yeah, for 2024, I would say that it's the same. But there is a lot of changes coming in this 2025, inshallah. Okay, we'll take the second. Go ahead, Susan.
Okay, I was just going to say there's one question here. If we're not certified for ICD-10 license, how can we get the list of diagnosis in the morphology? In order to use the code sets, you need to have a license from Saudi Health Council. Okay, so you need to contact them. If you don't have a license, you wouldn't be able to submit your diagnosis and procedure codes. So that is a prerequisite actually for onboarding to NAFIS. You must have your ICD-10 license.
Okay, regarding length of stay, we received an announcement from Tawniya. It should not submit it with the claim submission and enough to submit the encounter start and end date. Is this true? I think Susan
This is absolutely true. The length of stay is calculated and that can be calculated either by the payer, by CHI, or by the provider. It's calculated from the discharge date or the encounter end date minus the admission date. So this is absolutely true. You need to be careful with authorizations. There is an expected length of stay that is submitted, and that is actually given in the number of days by the physician, where they estimate how long the patient will be in hospital. But this is only for prior authorizations.
Another question from Ali. Could you please provide details about the changes made to the emergency code EMR within the subtypes code? Do you have an explanation for that, Rabia?
Yes, before, if we remember correctly, Ali, it was under institutional. You could only submit EMR with institutional type, and there was no encounter. Now, if the provider wants to submit the regular emergency, which is emergency visit, let's call it, just for the sake of conversation, outpatient emergency, in which there is no as in contrast to emergency admission to the hospital. So in this case, it will be under professional EMR, and he will have to fill also the encounter type as emergency, etc., with all the other required fields in the encounter. Regarding the inpatient admission, I believe Susan has all the details more than I do, and she has much better memory than me, because you had some comments about Susan in particular, about this particular case.
Yeah. So what I'd like to point out is that under institutional now, we are only looking at admitted care. But admitted care, when a patient is admitted, they're either admitted as an elective or a planned admission. They're admitted through the emergency department as an emergency encounter, or it might be something like immediate, which may be something like a patient who's admitted for a delivery. Okay, that's rarely an emergency. So we have introduced a new field, which is called admit type, or we call it admission type. And in NAFIS, the technical name for it is admit source. So every inpatient, when they're admitted, you need to provide the admit source, and that will tell you both where the patient was admitted through and what the level of urgency was. So it's either an admission through the emergency department, or the patient may come as a transfer from another facility as an emergency. Okay, so admit, the technical name admit source will replace that flag to show that this is an emergency admission. And Rabia, please correct me or add in on this. So this is the intention. So you have an emergency encounter. People are I think, familiar with calling this emergency services. These are non-admitted. So the patient just goes to the emergency department. But at the point in time when they are admitted into the hospital, that becomes an admission. And that's considered an emergency admission through the emergency department. Okay.
Thanks, Susan. Thanks, Susan and Rabia. So this question is asking to repeat what we just mentioned for morphology in Arabic. If you allow me, Susan, I will, and the others, I will say it in Arabic very briefly. طيب المورفولوجي كود basically لما تطلبها لما يكون في عندك كليم تحتاج دواء للسرطان، لازم ترفع المورفولوجي كود. اذا كان الدواء ما هو للسرطان تحط البرميسبل فاليو والقيمه المسموحه لها اللي هي نون ابليكابل ولا غير متطابقه ولا لا يوجد حاجه لها عند رفعها. هذا بكل بساطه. Okay, going back. So Dr. Radwan is asking, we still facing issue with payer that they do not receive last claim, and we called Nafis about the error. They directed to the payer again, and the claim time out after 10 minutes. But the payer has no solution. Rabia, do you have any answer to that?
Basically, Dr. Wael and everyone, in those kinds of tickets, if the error is a business error from the payer, this is when we tell him that this is from the payer, because it's not Nafis that gave the error. For example, just one example, let's say the patient, let's say I saw Ali here, so I will use Total Care as an example. Let's say I sent a claim for a patient who was actually BUPA to Total Care. Total Care will send a business error saying Rabia is not insured with me. Nothing Nafis can do about it. This is one example. So these are business errors, which are validations made by the payer systems. So from Jason's structure perspective, it's correct. Everything is right. The payer is there, but of course Nafis doesn't know who is insured where. So it will pass it to the receiver in the JSON file. Then the payer does his own validations to see that everything is correct. If everything is correct, it should be okay. Other than this, there will be a business error from the payer himself. What the providers should do, they should on their system categorize what's the error, and not just categorize it in one screen as error and then expect that it should be sent to Nafis. We check it, and if it is a business error, then we in this case he is directed to the payer. If it's Nafis error, we tell him how to fix it so that he can submit again. This is the procedure.
Okay, thanks, Rabia. And another question: if we are not certified about ICD-10, I think Susan already asked that.
Yeah, I have some other morphology related, and I'd like to address those while it's still fresh in our minds here, if you don't mind, Dr. Weil. So there's a comment that for a case which has an old treated case of breast cancer, you're facing the same issue, okay? And another person says an old morphology report is not of any benefit. Here is where you need to follow the coding standards. When you are reporting a case, you do not always code the cancer if the cancer is not active. You need to consult with your coding team and look at the coding standards, or send us a query on how to handle these cases with an example. So, for instance, if a patient was diagnosed with breast cancer and treated in 2004, is coming back and the physician documents that the patient had cancer, maybe they're having a follow-up of some sort, you don't code the cancer. You code the patient has a history of cancer. And when you code the history, which is a code that starts with Z, then you do not provide the morphology. So we have clinical edits coming up in the future that will, possibly will be helpful with this as well. Or no, it's handled already in the minimum data set. My apologies. But the documentation will also be available for you with the updated information that you will receive from Saudi Health Council, because this is very clear, and we will be doing multiple workshops to explain all of this information to you, okay, specifically. But right now, again, this is a coding issue. You need to go back to your coding teams and make sure that they're following the standards correctly on how to report these cases.
Okay, and then Mustafa asked a question. When recording for this session, I think the answer is yes. Okay, for Mahdi, أعتقد, sorry if I say your name incorrectly, for an eligible patient who needs immediate admission from ER, the emergency flag has been disabled after MDS update under institution. Could you advise? Susan or Rabia?
Sorry, Dr. Weil, I didn't hear the last part of the question.
The emergency flag has been disabled after the MDS update under institution.
Yes, correct.
Okay.
It's
Yeah,
moved now to
so-
professional. Yeah.
It's moved to professional, and we now have a field called admit source. Rabia, is there anything else that you'd like to add for that?
No, that's basically it. So depending, as you said, if it's an emergency admission or just a regular emergency visit, it will determine if there's an admit source or not. Other than this, it's only professional, and you put the emergency and counter type emergency with the other stuff that's under emergency profile. Yeah, that's
So again, admit source is only for the admitted care. That is the inpatient and possibly the day case. Okay. However, emergency department visits do not have the admit source. Okay.
Okay.
At this point in time.
Thanks, Susan. Asking a client about their marital status in optical shop is a challenge. They refuse to answer because they don't understand reason behind the question, while we will get only glasses. So we agree on that. I think if that's a permissible value is there, it's I would say acceptable. Okay, so then second, what should we do as a pharmacy with approvals already referred and approved to dispense by the insurance company for medication for cancer? The claim request is blocked due to the missing morphology, which we did not get with the approval itself. We tried to include it, but it always blocked because a missing attachment.
A missing attachment?
Yes, so I think the morphology codes, but it should be morphology codes, not an
Not an attachment.
not an attachment. Yes, so I think that's you need to submit the morphology code, not the attachment, to fix this issue. For dental center, is that mandatory to fill accurate vital signs value, as it's usually not applicable to get mostly? I think in any outpatient visit, even if you are in a dental visit, you should take vital signs, and these values again you can still fill it with not applicable, but vital signs I think for other accreditation standard it need to be provided.
Yeah. So check with your clinical teams and your accreditation, your quality management teams on how this is being handled in your facility.
Okay, for Saeed Ayman, so this MDS is for Nafis profiles, version 5.2 OBA and code concept, version 5.3. Rabia, is it the code concept 5.3? in the
Yeah,
OBA?
actually, doctor, actually, just to make things easier for everyone, once this MDS was released to production, we removed everything from the unified portal. So it is, yes, the OBA should be removed. It's a typing mistake, but yes, this is the one. So you will not find reference to any previous MDS now on the unified portal. It was all removed because it's pointless to have it anymore.
Change so randomly. I think we might have a session about the Saudi FDA code, Saad, to answer all these challenges. Does Nafis has any plan to standardize GTN and a Saudi FDA code? Yes, we do have a plan. We will integrate, inshallah, hopefully this year, with the Saudi FDA directly, and we will fix, inshallah, this issue systematically. So yeah, it's in the pipeline, and we will implement this, inshallah, this year. Do you would like to say anything, Susan, regarding it?
No, it's in the pipeline.
Okay. Yeah. Why the information of occupation and gender obtained by Nafis? It's required by some payers due to certain rules, especially for gender-specific interventions, and for occupation for also certain conditions such as occupational injuries and RTA. So yes, this information are required sometimes, but it's now mandatory. And again, we are trying to help you by getting these information from other sources. But right now, please provide it with each claim and prior authorization. Okay, please, we need to share emergency cases guidance with all market for both professional institution cases for better clarity. Is that possible, Susan or Rabia? Maybe
Yeah.
Rabia?
There was a communication that went out. We will review it and see if there's anything else that we need to add. Again, an inpatient admission may be considered emergency. It's the admit type. An emergency visit on its own, and there are two separate claims. One for the emergency services, where the patient is in the emergency department. Once they are admitted, you have a request. You may send a notification for that admission. That is a separate encounter, a separate claim. But it may be the admit type is the admission. Okay, so we will review the documentation that was shared. I believe it was about a week ago, and we will send out some additional guidelines.
Okay. Thanks, Susan. So is this workshop for new MDS, which started from December 1st? Yes. The answer is yes for that. For Islam Ahmed, is there any facility to make the chief complaint coded? So there is a plan to add SNOMED CT codes to the chief complaint, and that will be, inshallah, MDS phase 2, which I think it's the end of this month. Anything to add about that, Susan?
Yes, just to clarify, the reason that we've made the change is that the ICD-10 codes are not appropriate for capturing chief complaint. So the standard that we're using is SNOMED. Currently, you can still submit your text as you are. Yep.
Yes. So in the future, the SNOMED CT and text will be allowed, but right now it's only text. But no ICD-10 codes in the chief complaint. Okay, please explain the difference between period 1, period 2, period 3, and period 4 in data types. Rabia?
The answer is not like that. Actually, he has to read the difference between them. It's in the profile. So the first page is called data types. You will find like reference to these data types in the profile, but the first page in the Excel sheet is the explanation of every data type, how it should be given, how it should be used. Yeah. But it's not like simple as please explain the difference between them. It's not in anyone's head.
Okay, thanks, Rabia. Still, there is some payers that are following the new update of emergency plus EMR plus EER. Maybe Rabia for you that question also.
I believe the ER is for emergency admission. One of the codes for emergency admission, which is admitted through ER, is called ER. The code for it is ER. So it's institutional, professional plus EMR plus ER. This is what's meant by the question.
I think EMR and EER. I don't understand what the ER means here.
Okay, if he used EMR, then it's professional. So as Susan was saying, and we were saying, this is not the way to report admission. So if a payer is doing this, please let us know which one so that we can contact him and sort things out with him. Yeah.
So we are
Of course,
recording.
not here online. Send us by email. Don't make it public.
Yeah, by email. I'd just like to remind everyone the difference, okay? So you have your professional non-admitted emergency visit. Patient is in the emergency department and goes home, or they're admitted to the hospital. It's one encounter. When they are admitted to hospital, it's another encounter. It's a separate claim. So to track the fact that the patient was admitted on an emergency basis, you fill in the admission type, or as the technical term for it is admit source.
Okay, thanks, Susan. Another question, medical equipment like hearing aids should be sent in professional request or pharmacy, and patient share sent in claims should be inclusive of tax or should be sent without tax.
I think this question is a little not really applicable in this MDS setting.
Yes.
We may take that. You can always submit these questions to billing system or
Yes.
CHI info.
Okay, another question. Always we have claims queued by Nafis. We have to wait 24 hours to solve it. I think the queued is not by Nafis, it's by the payer. Is that correct, Rabir?
Yes, in most cases, if the payer doesn't respond in time, or then it will get queued. Yes.
Okay. Regarding submitting prior approvals for medications such as immunoglobulins, anti-cancer for admitted patients, should I send as a pharmacy, outpatient or under inpatient approval? For you, Susan, for prior authorization medication, immunoglobulin and anti-cancer for admitted patient.
Okay, for an admitted patient, this stays on the inpatient claim.
Yes, I think
Yeah.
that's the case.
Okay.
So the answer is inpatient claim, not as an outpatient. Okay, another question, is it mandatory to have license of oncology to pass the morphology claims and approvals?
No, I mean,
Yeah.
patients are seen, they can be diagnosed anywhere. The diagnosis may be clinical or it may be pathological. And at the time of diagnosis, the patient may not have started their treatment yet. So when you submit the claim and the patient's diagnosis is a cancer diagnosis, you submit it along with the morphology code.
Okay. Thanks, Susan. This question is in Arabic, but I'll translate it into English. Muhammad is asking, when we raised prior authorization and the response is invalid, how can we know the reasons? Is it the payer or the provider? Rabir?
Sorry, but you're seeing on your system that's invalid?
Yes.
Okay, let me put it this way. Please, you should ask your IT, because even if it's from the payer or from Nafis, there's a section in the error response which details exactly what is the error. You need to make sure with your IT to display this section and not say invalid, because invalid, it's a very generalized word. It can be for any reason. It can be from Nafis, it can be from the payer, it can be something, I don't know. So the best way, so that everyone will know what is the error, make sure your IT in this screen that is saying invalid, add a text box under it and display the description of the error. This way you'll know exactly what the issue is, whether it's from Nafis how to fix it, or also from the payer what is the issue. This way it will save you lots of guesswork and time.
Thanks, Rabir.
Dr. Weil, I've had a request again on how to obtain the morphology code. So I'm going to write in the content, the contact, no, sorry.
Sure.
The chat. I will put the information in the chat so you can look there. Okay.
Thanks, Susan.
The email as well as the instructions.
A request or a question from Dr. Rodwan. We are facing issue, recurrent error repeated by PUPA that is cancels the previous approval number when the request has, I think, new approvals. There is a CR that will, inshallah, be implemented very soon to prevent any previous approval to be changed from approval to reject. That will happen very soon, inshallah. hopefully that answered your question, Dr. Radwan, and please ask again if I did not answer correctly. What about dental admission cases? Should we keep under oral claim type or institutional? Susan?
Those go under the inpatient, under institutional.
So under institutional. Okay, for dental admission cases.
Yes.
Yeah. So another question from Muhammad. Professional as EMR is okay for emergency visit treatment, but if this patient need to be admitted, who is not appointed for our facility, how we will send the request as payer rejects, stating this patient is not appointed under our facility if we submit an institutional inpatient. I think this is a little bit complicated. Let me read it again. Professionals as EMR is okay for emergency visit treatment, okay? But if the patient needs to be admitted, who is not appointed at our facility, okay, what do you mean for admitted under someone who is appointed under your facility? How will send the request as per reject stating the patient is not under your facility? Do you understand?
But we would just reiterate again, professional EMR is for the emergency visit. When the patient needs to be admitted, they become an inpatient, and for that you submit the admit source as from the emergency department. That lets them everyone know that this patient is an emergency case. Okay, I'm not sure about what you mean by a patient who's not appointed for your facility. I'm not sure of that terminology. Maybe you could clarify this in the chat for us.
Yes, please. Okay, dental consultation consider under dental limit or outpatient consultation? I think under dental, if I'm mistaken, and correct me if I'm wrong, Susan.
I believe you're correct.
Yes. Okay. Again, a question about morphology. He's I don't know, A483 is asking. He said that we are adding the morphology code from the list, but it's being rejected many times. And the reason is the rejection reason is that there is no attachment supporting this morphology code.
Okay. Please contact us at CHI info or through any other appropriate method, and we will look into this with you.
Okay, as this question was in Arabic, I will answer also what Susan mentioned in Arabic. على سؤال المورفولوجي اللي لما رفعته من القائمة وقال لك ارفع attachment ارسل لنا ايميل على info@chi عشان نقدر نجاوبك. Thanks,
Okay.
Susan.
Yeah, I would like to point out that cancers are not always diagnosed with a morphology report. It would also be documented possibly in a discharge summary or in a consultation. And again, we will look into this with you. Thank you.
Thanks, Susan. A request for Nafis occupation list to apply to our system according to Nafis. I think this is not a question. This was repeated. Okay. A question regarding policy table of benefits. Many payers not showing details to know which service covered or which service need to be applied.
Yeah, I think these questions about servicing, these types of questions are the scope of this presentation. So please do send your questions in through the appropriate way, and we will answer them for you.
Yeah, for Saudi FDA and GTIN, as we mentioned, we are planning to implement fully with Saudi FDA, and this is what happened, inshallah, this year. It's in the pipeline. When requests are queued with the payer, it seems like it's lost on their end. They say that the identifier does not exist, even though it does in the portal. Question, Rabi', regarding the queued.
Okay. Let me just put it this way. If you can see it in the TV and the transaction viewer of Nafis, it means it passed successfully through Nafis and it reached the payer. Okay. Because the transaction viewer does not show provider requests that gave an error in Nafis. If it gave an error at the provider, it will at the payer end, it will show a status of error in Nafis, so you can actually see the response for it. Okay, but if the request is successful and you see it and the status is, let's say, pending, approved, etc., it means it's an error. If it's queued, it means you passed it correctly and then the payer did not respond. This is the meaning of the status of queued in the Nafis portal. Okay, so the TV is the ultimate proof that you passed it correctly.
Thanks, Rabi. Is it possible to get a copy of a request by just providing an identifier or bundle ID due to requests that are lost after being sent and received, but then getting an error? Get a copy of request by just providing.
If it is a business error from the payer, he can download it from the provider portal, the JSON file. If it is an Nafis error, he can send a mail to support because there's no way to download it with the bundle ID that he's talking about. But the ideal scenario is that all these requests should be saved somewhere on the system in the database. They shouldn't be lost. This is the ideal scenario. So because you will need it later on for submitted claim for these requests and stuff, there's use for it. So, but if, as I said, if it's a payer, a business error from the payer, you can download it from the Nafis portal, from the TV transaction viewer. Other than this, if it's a validation rule from Nafis, send an email to support and they will send you the JSON file.
Thanks, ربيع. دكتور أبرام، هل سيتم شرح المحاضرة بالعربي؟ This is a technical session, and we believe that most of you should speak English, otherwise you won't be able to do any of these changes. So please make sure you consult with your team to see if somebody can speak English who can actually apply these changes within Nafis. Okay, another question, Mr. Hamad, or Hamad Medical Center, we send the prior authorization approval of, okay, so this is not, the limit of the consumption is not part of this MDS workshop. Medical equipment like hearing aids should be sent as a professional or request or a pharmacy. I think if it was from an outpatient, it should be as a pharmacy. And correct me if I'm wrong, Susan, for medical equipment, hearing aids.
I will have to get back to the team on this.
Let me save you some time, Susan. Pharmacy transactions, if it's a pharmacy, as Dr. Wael said, because they are medical devices. There's a URL in the fees, which is medical devices, and you can use it for pharmacy type claim. Because if you are a pharmacy, not a hospital, and you choose to use professional, you will have to provide the physician, and you don't have the physician credentials. So you will get an error from Nafis where's the physician just because you put professional, because professional requires professional approvals or claims require the physician, while the pharmacy don't. So you will have to use pharmacy if you're an community pharmacy and you are giving out a claim. So I hope this will help you.
Thanks, Rabia. I think also, Rabia, this question, maybe you could answer it. Well, it's a question about the follow-up. The patient is getting the prior authorization services. Then after 2 days, he asking for more services. Should they send the follow-up with this previous approval?
Yes. No, it's not with the previous approval. He will send something called prior related request, a related authorization request with relationship type prior. And this prior, he'll put the previous ones plus the new ones. Always send the latest version and not the difference between the items. If you send the difference, you will be canceling everything previous and only requesting the new ones. This is what it means if you send only the difference. So if you want to add services or modify, always send the latest version of the approval, which means old plus new or old plus changes, whatever is you're trying to send. It's not about the authorization. You will refer related to the previous one, the identifier of the previous authorization, and not like the approval number of the previous authorization.
Okay. As per Nafis guidelines, pharmaceutical approval should go as a pharmacy, outpatient. So how we can submit pharmaceutical for inpatient? I think it should be as it is.
I believe there was a guideline which was sent out by onboarding on this. Let's make it clear since we're here. Please, since you guys are CHI, you are the regulator. If I say something out of line, just stop me and say you're wrong. I believe as per our understanding, that you're talking about separation of medication items in the claim. This is what you're asking about. This applies to medicines that you take and go home. Take away medication. If you are in the ER, you will submit it under the ER request. if you are
Mhm.
admitted, these medications, the price includes the nursing fees. It's not SFDA price. If you put them as pharmacy, then you have to put the SFDA price or the GTIN, and then automatically it will accept only the price of the medication, and you can't add the nursing fees to it. So, in admitted
the
medications are
seven-
under institutional, ER are under ER. The only thing is
Correct.
under pharmacy is the takeaway medication.
That's
yeah,
correct.
outpatient. Okay.
But the take-home medication, Dr. Weil. So when the
Yes.
patient is discharged and has a prescription that needs to be filled, that goes as a pharmacy.
Okay.
But anything done
so
on an inpatient basis will be on the institutional, the inpatient claim.
correct. Okay. Is there a sample for MDS for the CNHI notification request? What has been provided are claim requests only. I think this question also another question regarding CNHI notification. It's out of this scope, so I will leave it for now. You can send please these questions to info@CHI. For your Einstein, it's not called cancellation as per HL7 latest approval container all the new approved items. It overrides previous one without impacting already approved items.
So I think that's the same one that Rabia just
Yeah.
addressed.
Okay. And then a question from تجمع صحي ثالث. Thank you for valuable information. We thought we need to summarize a note referral to our knowledge. Okay. We have this recorded and you can refer to it please as needed. And I think usually we correct me مساعد and anyone from onboarding team if we're gonna summarize these questions and make it available for everyone. Not appointed means member not covered under our facility. So that's the answer, Susan. The question that was regarding the prior authorization.
So this one, I would refer back to the essential to the documentation that defines how emergency cases need to be treated. Again, I off the top of my head, I cannot remember this. Apologies, but this is very well defined.
Okay, thanks, Susan. We have a
Okay.
question from Radwan. Also, it's not regarding the MDS. Please send it, and we can investigate it. He's asking about the billing error, number 17, incorrect billing, and the payer said that many providers had the same issue. So please send an email, and we will investigate it. As we have received RTA type diagnosis appendix, can we also get WPA type diagnosis as well? Currently, only one code is there, Y96, work-related condition. Kindly confirm if this is the only one.
That is correct. It is the only one.
Thanks, Susan. Vendors do not have
So just, I will add, when you submit this, this is just for the accident type, you still need to actually code the injury that happened. So this is a supplemental code and will never be in the principal position. Okay?
Okay. Vendors do not have access to client portals. I don't know what's your question, Ahmed. For some, okay, in this case is an issue that would request that reach Nafis, but the other party says they did not receive it because of error 504. Please submit this. Again, this is not related to MDS. We'll be happy to investigate it if you send it by email, Ahmed Al-Mansari. For some cases, canceled prior authorization not reflecting in our HIS. What we do to be updated in our HIS? I think this is a technical question. Rabi, do you have an answer for that?
Yes, fix your HIS.
Okay.
It's the HIS that's not showing the cancellation. So there's an issue with HIS. It's not showing them. So he needs to check with his IT to see what's the issue with the HIS.
Okay. Another question from Muhammad Dawara. How we read JSON respond or JSON request? When we look into it, it's only happen as codes. Do you have an answer for that, Rabir? I don't understand.
Okay, I can give him advice. It's not like an answer. I'm actually a pharmacist, so by practice, you will get to know the JSON file like I learned. There's no way to teach JSON like in a session or by a question. So basically, what you do is like follow up. For example, if you want to know where the iqama is or the national ID, take the iqama of the patient from your system, do Control F, and look for it. You will know that you will find the patient. This way, by practice, you will get to know where all the fields are. It's not something like that can be taught in 5-6 minutes. By practice, it's easy, but you need some practice with it.
And generally in an institution, there will be technical people who have experience with reading these files.
Okay.
If someone wants to understand them.
Thanks, Susan. So a question from Saeed. When sending a batch of claims, the fees takes more than 20 seconds to process these requests. And is this a normal behavior from the fees in case of claims are more than 30 to 40 seconds? Rabia?
That depends on the size of the claim and how many people are submitting at the same time, because you know that most hospitals, they submit most of their claims in the first, let's say, 5 to 10 days of the next month for the previous month. So it's like a rush hour on a highway. So the bigger the size of the claim, it will be treated as a large claim and will be separate in a separate queue so that it will not affect the overall process. And also the number of providers submitting requests, it also has an effect. And then there's a capacity for everything, and Nafis is one of those.
Yeah, thanks, Rabia. We are not getting a response from eligibility request. I think this is not related also to this session. Could we please could we have a designated list for the mandated fields through the fees and this? Possible for like an Excel sheet or something like that?
This is in
Yes,
progress.
Susan, I know.
It is under validation, and we plan to release this in the very near future.
Yeah. Asking for CNI. I have
Your voice,
send me your request
Dr.
by email
Weil,
also.
your voice is pausing. We're breaking up.
Can you hear me now?
Yeah, we can hear you.
Yeah, any contact persons for CNHI technical cases rather than the email, we have many issues. I cannot speak on behalf of CNHI, but please send your request to an email. We will try to connect you to the right person. I have 2 services yesterday and get approved. Today, as I follow up, adding 1 new service, but this is rejected all the 3 services. Can you tell me about this? Again, Pathan, not regarding this MDS, please send your request by email. We are trying to answer all the questions related to MDS. Is there any way to get all the generic and brand names for each generic name approved by the council? Again, you can send your request through email. We can help you with that. We are almost reaching the time that will end up. Hopefully, we are answering most of the questions. For pharmacy, which data from MDS is mandatory to collect from the clients, knowing that some clients are very sensitive about requests to show their IDs or share the required data. Data of birth, marital status, and occupation. Some clients provide a wrong data just to get their request submitted. For pharmacy, the approvals is happening from the provider side. So you can fill non-applicable. It will affect your prior authorization status. But very soon, we will have the date of birth validated. So these data, it's being submitted in the wrong way, it might be rejected. So we highly recommend against this kind of practices, maybe not applicable if you are only dispensing the medication. But again, this is also could be used to validate the identity. So we recommend not to fill a wrong date. Is there any way to view recorded meetings? Yes, we will share that. I think this is the last question I have. For an ongoing admission, how is prior going to be handled? Is this an old plus new? Do you expect 20 line a day by previous day admission plus the extension? Note extension for admission is sent day by day. Susan?
I think this is out of scope for this meeting, but this is a very good question, and we would appreciate if you can forward this to us by email.
Okay. That's the last question that we had answered. Please, all the questions that are not related to MDS, we will be happy to answer them by email. please email us and let us know how we can help. As I mentioned, there is few changes are coming. We would really appreciate your support. We would like to provide you with all the support you might need, but more changes are coming, more validations for the data that we are asking on the fees. You will be able to, we will be able to validate these data by your help. Please make sure you fill it the right way, use it the purpose that intended to be, especially when we talk about permissible values. Again, we will be sending notifications, emails about the providers before we send that to supervision and we communicate that to payers. But payers will be able to validate your request very soon by applying some of these rules for data quality, for MDS completeness, and validation. Thanks, everyone. And Susan, do you have anything to add?
We're very pleased that we've had such a good turnout today. We appreciate all the questions. And if in the meantime there's any additional questions, you know how to contact the team.
Rabia, anything to add?
Just thanks everyone for the good audience. Nothing from my end.
Thanks everyone. Inshallah, and see you during next session. يعطيكم العافية. مع السلامة.